Good morning. I'd like to call this public hearing of the Committee on Health to order. Today is Thursday, July 13th, 2023. The time is 10 a.m. I am at-large Councilmember Christina Henderson, Chair of the Committee on Health. We are in room 412 of the John A. Wilson Building. This is a hybrid hearing with public witnesses testifying virtually and government witnesses testifying in person. Today, we will consider three pieces of legislation before the committee. Bill 25-226, the Access to Emergency Albuterol and Glucagon Amendment Act of 2023. Bill 25-73, the Ambulatory Surgical Facility Amendment Act of 2023. And Bill 25-312, the Health Professional Licensing Board's Residency Requirement Amendment Act of 2023. I introduced Bill 25-226, the Access to Emergency Albuterol and Glucagon Amendment Act of 2023 in March of this year, along with Council members Charles Allen, Zachary Parker, Brianna Doe, Anita Bonds, Brooke Pinto, and Janice Lewis-George. This legislation would authorize employees and agents of public schools who have been certified under the Office of the State Superintendent of Education Training Program to administer undesignated albuterol to students who are suffering or about to suffer an asthma attack, and undesignated glucagon to a student who is suffering or about to suffer hypoglycemia due to diabetes. Currently, students enrolled in public and public charter schools must have medication action plans to self-administer inhaled asthma medication and diabetes medication. A parent, legal guardian, or a student must obtain authorization on the medication action plan from a licensed practitioner to enable the student self-administration of medication. However, in the case of an emergency where a student without medication plan is showing signs of an asthma attack or hypoglycemia due to diabetes, school staff are currently not permitted to administer undesignated medication to the student. There's also currently no undesignated albuterol or glucagon available at public or public charter school campuses. In the district, only 15.2% of students with asthma have an asthma action plan on file. I'll say that again. Only 15% of students who have asthma in the district have an asthma action plan on file. 71.7% of students with diabetes have a diabetes management plan. Therefore, in the case of a medical emergency, almost 9 in 10 children with asthma would not be able to access albuterol, and 1 in 3 children with diabetes would not be able to access medication that they need. This legislation, crafted in close collaboration with Children's National Hospital, seeks to address these health risks by requiring undesignated medications to be available and safely stored at all public and public charter schools. The second bill we'll consider today, the Ambulatory Surgical Facility Amendment Act of 2023, was introduced by Chairman Mendelson on behalf of the mayor in January of 2023. This bill makes several changes to the district's laws pertaining to ambulatory surgical facilities, which are entities that provide outpatient surgical procedures outside of a hospital setting. This legislation would enable DC Health to finalize regulations for the ambulatory surgical facilities that have been held up by DC Code provisions that have been held up by DC Code provisions that have made it challenging to promulgate these regulations. Specifically, the legislation adds several definitions and removes the requirement that regulations governing ambulatory surgical facilities list all procedures that they can be performed only in such facilities. The third legislation we will consider today is the Health Professional Licensing Board's Residency Requirement Amendment Act of 2023, which I introduced in June, along with Councilmember Zachary Parker. This bill aims to address the high number of vacancies that we have in our DC health professional licensing boards, particularly boards where a significant percentage of health professionals under their jurisdiction do not actually live in the District of Columbia. For example, the Board of Medicine has 15 seats and currently 7 vacancies. The Board of Nursing has 11 seats and currently 5 vacancies. To address this, the bill would allow for up to 50% of the board to be filled by health professionals who are not district residents, but are licensed in the district. These board members would still need to be licensed here and practice for at least 3 years prior to their appointment and during the time that they serve on the board. I don't see any of my council colleagues who have joined at this time, but should they join, we'll pause and allow them for opening statements. So I'm going to turn to our public witnesses. Before starting, I want to review our testimony guideline for public witnesses. So public witnesses representing organizations have 5 minutes to speak, and witnesses testifying on their own behalf have 3 minutes. Please be conscientious of your time, and I'll give a nudge when time has expired. I'll now call the first panel of witnesses. For those who haven't joined us for a hearing before, you'll need to affirmatively accept our invitation for you to be elevated as a panelist in order for you to join us in the room. So let's see here. Okay, we have folks who are speaking on different pieces of legislation. So I'll start with the first panel, which will just be on the Access to Emergency Albuterol and Glucagon Amendment Act. So Rachel Johnston, who's the Senior Director in Operations for DC Charter School Alliance, Dr. Andrea Boudreau, the Executive Director of, I think it's School Services at Children's National Hospital, and Shipla Patel, who's the Medical Director for the Impact DC Asthma Clinic at Children's National Hospital. Give it a minute. Okay. I see Rachel. So Rachel, why don't you go ahead and get started?
Good morning, Chairperson Henderson and members of the committee. My name is Rachel Johnston. I'm a Ward 5 resident and the Senior Director of Operations and School Support at the DC Charter School Alliance, the local nonprofit dedicated to ensuring all students in DC receive the great public education they deserve. I want to start by thanking you for your leadership, along with DC Health, OSSE, DBH, and Children's School Services for working hard to make sure students have equitable access to public health resources. This includes actively engaging to make improvements in streamlining administration of medication training for schools, as well as increasing access to life-saving drugs like EpiPens and Narcan. Ensuring students' health needs are met is a crucial step to being able to actively participate in learning. I'm here today to share our support for the Access to Emergency Albuterol and Glucagon Amendment Act of 2023. All students, pre-K through adult, should have access to these important medications while at school. We appreciate that this legislation requires the city to supply these medications to schools and aligns with nationally recommended best practices that many other states have passed or are considering to strengthen public health access for students. My testimony today will offer a few recommendations for the implementation of this program that we believe will make this bill stronger. First, we recommend consolidating all medication administration, training, guidance, and management in a single agency. With multiple agencies overseeing each process, it's confusing for schools to remember which is responsible for each when they have questions. It also increases the possibility of duplicative components of training. Lastly, reporting processes and compliance requirements aren't always the same across agencies. School staff aren't healthcare experts. They need this streamlined to ensure they can support students. Second, we appreciate and support the need for closely monitoring medication supplies, but we believe there's an opportunity to streamline the reporting for the stock supply of all 4 life-saving medications in schools, Narcan, albuterol, glucagon, and EpiPens, to ensure the process is simple, clear, and efficient. Third, our schools believe it's important to ensure their families have the assistance they need to secure prescriptions if necessary. We think this legislation could be strengthened by including a requirement that school nurses reach out to families after administration of stock albuterol or glucagon to ensure they have up-to-date prescriptions or access to these medications, and to create a medication plan with the family if they don't already have one. For schools that don't have an assigned school nurse, we request that OSSE, in consultation with CSS, designate staff responsible for prompt family outreach. Fourth, we recommend the legislation be strengthened by requiring the agency overseeing the administration to purchase inhalers with spacers, as recommended by the NIH. The link to this recommendation is in my written testimony. This allows the inhaler to be used for multiple individuals with less cleaning. Fifth, because glucagon has some serious side effects, we recommend ensuring appropriate safeguards are in place to mitigate this risk, especially when school nurses are not present for administration. For example, many states with similar legislation have limited administering glucagon only to cases where a medication plan is in place for a student. And finally, this bill already includes many recommendations from the NIH for improving medication access in schools, but we think it can be strengthened by aligning on all aspects, including providing explicit immunity from civil liability for staff and prescribers. As always, charter schools value the health and well-being of their students first and foremost. The DC Charter School Alliance is grateful for our partnership with the city, and we welcome the opportunity to continue collaborating to make sure every student has their health needs met so that they can actively and safely engage in learning. Thank you for your time and attention, and I welcome your questions.
Thank you, Rachel. Dr. Boudreau? You are on mute, Dr. Boudreaux.
Sorry about that.
There you go.
Okay, good morning, Chairwoman Henderson and members of the committee. I'm Dr. Andrea Boudreaux. I serve as the Executive Director of Children's School Services at Children's National Hospital. Thank you for this opportunity to speak in support of Bill 25-226 and the impact that rescue medications will have in our schools. Children's Nationally fully supports the legislation to allow for rescue medication in schools. In 2015, this body approved legislation to allow undesignated or stock epinephrine to be in school to treat children in anaphylactic emergency. Today, we want to share how impactful these medications can be on children's lives and school attendance. Just as the EpiPen can save a life, so too can glucagon and albuterol. We are happy to report that they are not regular emergencies, but I caution council to look at the number of incidents as a sole factor of determining efficacy. The prevalence of students with type 1 diabetes is much lower than many other pediatric illnesses, but its impact on their quality of life and the danger of hypoglycemic incident is real. Making glucagon available in schools is life-saving. As devastating as a picture of a child wheezing and struggling to breathe is, the picture of a hypoglycemic child is even worse. Seizure activity and loss of consciousness are both realities from a child whose blood sugar is too low. Glucagon in an emergency can save that child's life. Unfortunately, for so many of our families, glucagon or sugar tablets are not seen as a priority because of their experience with type 2 diabetes and the constant work to minimize sugar intake. There's a significant difference in the way that type 1 patients experience their illness and the dangers of both extremes. Having access to this emergency medication to restore their levels is literally a matter of life and death. Now to the importance of albuterol, and one that I think many of you are more familiar with. Earlier this year, I shared the story of a student, Jay. For those who don't remember him, he's a middle schooler in Ward 8 who had been escalated to my attention by our data and quality team because he had been in the emergency room 4 times between August and December. Because of his illness, Jay's doctor shifted his medication from being administered at home to being administered at school. And in preparation for the upcoming holiday, we wanted to ensure his family was prepared to care for him. Jay has not returned to the emergency room as a result of an asthma exacerbation because we're able to support his needs at school. Unfortunately, for so many other children, that is not their reality. Be it affordability, access to a provider, or just being a kid, children show up in our health suites every day in need. And access to albuterol in an emergency can keep a child in school, prevent the trauma of exacerbation, and prevent the emergency room visits. This year, there are 12,338 students with asthma who are enrolled in schools who participate in the school health services program. Of those children, there have been 304 missed days because of their illness. In addition to those who missed school, 269 left school with a parent and 60 left in crisis in an ambulance as a result of an asthma exacerbation. Dr. Patel is going to talk to you about the etiology of asthma, but let me tell you what our nurses and health technicians see when these children come into the health suite. Imagine feeling like you're gasping to get air through a straw. That pain and that fear is what 12,338 of our children in district, public and public charter schools experienced this year alone. According to the Centers for Disease Control, 10% of children in the United States have asthma, but in DC, 14.5% of our children suffer from this chronic illness. While we are always focused to lower the percentage of children experiencing complications from this chronic disease, today we're here to express support for the medication tools that will help us respond to the children when they present to our health suite in crisis. There are 2 components to albuterol administration, the inhaler and the spacer. The benefit of the spacer is twofold. The spacer ensures that you get the most medication into your lungs, but it also allows us to provide one inhaler for each of the 207 schools that there's an asthmatic child, because we can use the spacers to share that inhaler across the student population. It is also important for you to understand that this can increase the chronic absenteeism that we experience in the district as well. Parents sometimes fear sending their children to school when they had a crisis at night or early in the morning. This would allow us to afford them the opportunity to feel comfortable sending their children to school. The whole school, whole child community, whole school, whole community, whole child model that we use to create this health services program places the child at the center of education and public health and school intersection. This bill brings us one step closer to ensuring that the child we are focused on can learn because they have access to rescue medications. Thank you for the opportunity to testify. I'm happy to answer any questions you have.
Thank you. Dr. Patel?
Hi, good morning, Chairwoman Henderson. Thank you for the testimonies that have already happened. I'm going to reiterate some of those and try to keep it short. My name is Shilpa Patel. I'm the physician and medical director for Impact DC, which stands for Improving Pediatric Asthma Care in the District of Columbia here at Children's National in Washington, DC. I appreciate the opportunity to provide testimony today regarding access to emergency albuterol and glucagon legislation. For over 20 years, Impact DC has been caring for the district's children. Our goal is to always steer children away from episodic emergency department use and towards more effective primary care. To that end, we not only provide services directly, but we also work with our schools, our community, and to improve healthcare access for these children. With data housed in our asthma registry, and these numbers have already been shared, it's a population health data management tool unique to DC and supported by DC Health. So we thank DC Health. Impact DC has been able to track the district's asthma utilization. And we know from that there are 17,000 children in the district with asthma. And we heard how many of those are in the DC public and charter schools. And of those children, 17,000, we had almost 7,000 ED visits in calendar year 22 made by those children with asthma. And of note, Children's National here in the district sees 1% of all ED visits made by children nationally for asthma. So as we've already expressed earlier, the disease burden in our district is higher than other places. Our program has a strong partnership with Children's School Services, and we work with Dr. Boudreau. We ensure that all children seen at Impact DC have an up-to-date asthma action plan and try to work one-on-one for those patients like Jay who needs a little bit more. Despite this, there's still children, unfortunately, that we're not able to reach. And unfortunately, these children do not have access to emergency life-saving medications such as albuterol at school. I'm going to borrow heavily from Dr. Volerman and colleagues. They're school-based asthma experts who published an excellent statement, which I encourage everyone to read, called Ensuring Access to Albuterol in Schools from Policy to Implementation. My testimony today borrows from that. School-age children spend a majority of their day in school, and guidelines recommend that all children with asthma have access to quick relief medications. However, access to emergency albuterol remains low, and studies show that few as 14% of children nationally have quick relief medication at school. Common barriers include difficulty accessing healthcare, challenges to obtaining an asthma action plan, expired or lost medications, or sometimes not even knowing that they have a diagnosis of asthma. So compared with peers nationally, children with asthma miss more school days per year, totaling 14 million absences annually. Because children may experience a sudden, unexpected, life-threatening exacerbation, sometimes these are high school athletes, delay in albuterol administration can cause significant harm to these children. And 1/3 of asthma deaths are because of a delay in asthma and albuterol administration. Asthma-related deaths have also occurred, like I mentioned, among athletes who don't know that they have undiagnosed asthma. So undesignated stock albuterol available in school is a practical mechanism to ensure that students with asthma and those with potentially undiagnosed asthma have access to potentially life-saving quick relief medication at school. Schools with the assistance of a medical consultant, as mentioned earlier, appropriate training for staff, appropriate training about spacer use, and Impact DC is happy to help with that, will ensure that these untoward experiences will not happen, and they will not affect the most under-resourced children in the city who can't get the asthma action plan or don't have a medication at school. These policies have increased across the United States, and it shows that these are safe and effective for children with respiratory distress. To summarize, the intent of this bill before you is to ensure that there's access to children who don't either have an inhaler, can't afford, or for whatever reason have lost their inhaler. Anyone who's experienced asthma, as Dr. Boudreau even mentioned, is the worst thing dealing with it. There's nothing worse than dealing with a child watching in front of them struggling to breathe. and it only takes seconds to get the rescue inhaler to really help them. By passing we can help alleviate this burden, which is proportionally cares to under-resourced children in the city. Thank you so much for this opportunity, and I'm happy to take questions.
Thank you. And thank you to all of the witnesses. I do have a few questions. So Dr. Patel, I'll actually start with you because some of my questions, I guess, are a bit more technical in nature, but
Sure.
are important in terms of us moving forward on this. What's the typical shelf life of an inhaler?
So there's an expiration, and you can even use it after, but it's usually 1 year that we say. So a school will have 1 year to use the albuterol inhaler. Although to exact shelf life, I'll have to look up, but I'm pretty sure albuterol in schools policy is we need a new asthma action plan every year.
Okay, so this isn't a situation where we would need to be providing the school with like a new inhaler every 3 or 4 months, but it's something that perhaps can get them through a school year if it's provided at the start of a school year.
Yes, and if just to put into perspective, currently we have lots of children with albuterol inhalers in school that go sometimes unused for the mild asthmatics, and for the ones that need it, we need to get even another one, and the prescriber will send another one when the parent tells you. So having one would actually help this problem because you're actually making it a more efficient process where each kid can have a spacer which does not expire. And there are actually also paper cardboard spacers that people use as disposable spacers. So there's many options there.
Okay, so the larger expense or larger supply need would be on the spacers of needing to have multiple employees. Okay, got it. Are there potential negative health consequences associated with administration of glucagon or albuterol? Particularly, well, sorry, you focus on asthma, so I'll focus on albuterol. Particularly if a child is not experiencing an asthma attack?
No, and this happens at home as well. Just to put into perspective, parents are empowered to give albuterol to their children at home, and often, they'll have given it once and they're like, actually he didn't need it, and they move on with their day. Albuterol will raise your heart rate a little bit, may cause a little jitteriness, but with the doses that we're recommending, it shouldn't cause any problems.
Okay. And how quickly, is I heard you in your testimony was actually a question I had around, there are certainly individuals who might experience an asthma attack without having had a prior diagnosis of having asthma. I think we've all heard stories of athletes who the student was on the baseball field and then all of a sudden there was a situation that occurred. How quickly does someone need to be treated to avoid negative health consequences as a result of an asthma attack?
So if it's an asthma attack and someone can actually go ahead and give their albuterol even within a couple hours, it's totally fine. The benefit of having it in school and having it immediate is to give them immediate relief. The earlier you give it, the less risk of them proceeding to need an emergency department evaluation. So even at home, for instance, we ask parents to look for triggers or even the first sign of a upper respiratory tract infection, if that's their main trigger, to go ahead and start albuterol. So if given within, even an hour of someone saying I'm having a little bit of trouble breathing, it'll still help them. But the earlier you give it, the less likely they're going to need more where they end up in the emergency department. And that's kind of the benefit of having it at school. So we don't wait for them to get home, maybe picked up by a parent, or even get to the emergency department if they need to be there, and go ahead and give the albuterol as soon as we can.
Okay.
And the effects are within minutes.
Great. Dr. Boudreau, so the proposed legislation requires that at least 2 employees on a particular campus be trained in the medication administration. Would nurses or school health associates be able, should nurses or school health associates be considered as one of those trained individuals?
Absolutely. And in fact, with the proposed language regarding our new staffing model, those student health technicians would be trained and able to be present. And there should be a school health services program staff person on every campus next year.
Okay. And so in terms of, I guess I'm just trying to think about like, who's the other person in the building? Because there are things that happen during the school day, but then we have a significant amount of kids who participate in after school activities, aftercare, et cetera. And I'm thinking, at least my kid in aftercare, it's a lot of running, it's a lot of climbing, a lot of activity. So should we provide some additional guidance here that it should be someone who is not just there in the morning, but is present throughout the school day?
We still recommend the administrator of medication training that CSS provides for the district.
Okay.
We provide it for school health services program and those campuses that do not participate in the program. We still encourage that, and the training of albuterol administration as well as glucagon is included in that training.
Okay. So let's talk a little bit about glucagon, because we've talked about albuterol a bit. Ms. Johnston, in your testimony, you talked about how several states who have legislation like this would only allow for the administration of glucagon when a plan is on file. Can you speak a little bit more about that?
Yeah, so we did just a little bit of research to understand what other states were doing. And we dug into a little bit about what the side effects look like for glucagon. I actually just recently went through the AOM training myself with CSS to better understand the process. And it's a little bit more complex than albuterol. It has slightly more severe side effects. And so one of the things we just want to make sure is that, especially if there isn't a nurse present to administer, that there are additional safeguards in place. And one example could be that only for a student who has already a medication plan on file, but there are other additional safeguards that could be there instead to make the access more widely spread. But we just want to make sure that the person who is administering the glucagon has the proper training to be able to diagnose that the person who is suffering from hypoglycemia or the symptoms of hypoglycemia actually have diabetes and need the drugs. Mm-hmm.
So, I mean, I think when I look at the numbers in terms of the number of kids we know who have asthma versus the numbers who have an asthma plan on file, and the number of kids who have diabetes and the number of kids who have a action plan on file for that, there's definitely a difference here. And so is there any particular reason why we shouldn't move forward with just undesignated albuterol? Because it seems as though the kids who have diabetes, for the most part, those families are providing what is necessary.
Did you want to take this one, Dr. Boudreau?
I mentioned that in the testimony, Chairwoman. The challenge is families provide insulin. The glucose tabs are a challenge to have access to. Many families understand the importance, and so we're talking about the glucagon. I would be glad to have our team prepare you some statistics on need for insulin as well, but today we're talking about the glucagon, which is a completely different vehicle of medication. It is for when you're hypoglycemic, which means your blood sugar is too low, and we need to get that up. So any child who's hypoglycemic, we would still have to call 911 as we do with the EpiPen today. And so if an EpiPen is administered, you still go 911. What happens though is we're preventing you from dying en route to the hospital. The same thing would be with the glucagon. So they would still have to call 911. The child, again, like I mentioned, seizures, loss of consciousness are the symptoms that we're trying to abate. The reason the gel is actually recommended is because it's something that can be administered even if you've lost consciousness. So with a child with hypoglycemia, we think it's still important, even if there's not a diabetes medication management plan, because 911 still needs to be called. But those seconds are critical.
Okay, and what's the shelf life of glucagon?
Let me get back to you on that. Dr. Kogan wasn't able to be with us today, and there's actually a new medication that's been recommended that we will provide some information to you that can be stored, does not require refrigeration. And so I want to get that to you, that new medication. Okay.
That's a question that we could sort of work through, because but it's going to cost, unlike our EpiPen situation, this is going to cost us some money. And so we're going to have to do some calculations out in terms of how often we're going to have to do this and, kind of go in that direction. Speaking of the administration of medication training, how often do you all, so one of the things that Ms. Johnston, you brought up in your testimony as a suggestion was to have all medication trainings in one agency. CSS does one. I think we have OSSE doing EpiPens. It makes sense for
DBH does
consolidation.
Narcan.
I'm sorry, say that again.
DBH, I believe, does Narcan.
Okay. And I'm listening. I'm sort of getting everybody to play in a sandbox together, to everybody just have one person do it. That's going to take some, well, we can work through that, but that's a good point. So thank you for raising that. Dr. Boudreau, how often do you all do administration of medication trainings?
Throughout the school year, we have 2 per month.
Okay.
During the summer is a little less frequent, but through the school year, it is 2 per month that we have the in-person. So staff members get a modules and access to a manual where they can prepare for the in-person course. And then they come in, but we offer the in-person course twice a month.
When you guys do your training, do you cover EpiPens?
So that is a part of the in-person module. All 4 rescue medications are covered in the in-person module.
Do you do Narcan too?
Mm-hmm.
Okay. All right. I see a path here. We just don't have to.
We train on it. The oversight, to explain what Ms. Johnson is saying, the oversight is with the different agencies, but the training is all a part of AOM. So if a person has an AOM certificate, they have been trained by CSS to do that, to administer that medication.
Right. And I don't think we necessarily want to minimize it, because I think that there might be people who are just interested in Narcan administration training and don't want to go through the whole AOM. It's like, how many hours is it?
8 hours in person, typically about 10 hours of the online preparation before the in-person course.
So it's a healthy commitment.
It is.
To a school community to take that training and to get certified on that. So, okay. I appreciate you all being here today. Dr. Boudreau, you're here. And I think there's like 50 something days to start a school. How's it going on hiring all of your new people?
Wonderful. We actually had another large group yesterday, and we have an even larger class we're anticipating next week. We have people in first aid training right now. So things are looking great. We're very, very excited to send some new numbers to you.
Okay, great.
Yeah.
We'll check in on that, because we want every school to start the school year with their new person on board. And you all have the information for new schools that are opening for school year 23-24 who want to participate?
So I am aware of 1 DCPS school and 2 public charter schools. We've been working very closely with the charter school board on those schools. I understand there are some schools who are requesting, who have not been a part. They're not new schools, but they're requesting to be a part of the program. And we will ensure that there's support for the schools. Everyone in the program will have 40 hours of coverage. We're sure about that.
All right. Thank you. All right. Thank you so much to all of these public witnesses. We're going to go on to the next panel, which will be on the other 2 bills, health professional licensing boards, and then ambulatory surgical facility amendment. So if Leah Kaslas from DC Children's Law Center, Melissa Millar, and Kurt Gallagher can join us, and then Dr. Serena Floyd from Planned Parenthood, if she can join us. We'll give it a minute.
Hello, can you all hear me okay?
Yes, we can, Dr. Floyd. We're going to start with Leah.
I'm here, Chairperson Henderson, if you'd like me to get started.
Yes, I see you right now, so go ahead.
Perfect, thank you. Hello, Chairperson Henderson. My name is Leah Kaslas. I'm a policy attorney at the Children's Law Center and a Ward 5 resident of the district. I'm testifying today on behalf of Children's Law Center. Our more than 100 staff work with DC children and families, community partners, and pro bono attorneys toward a future where every child can grow up with a strong foundation of family, health, and education, and live in a world free from poverty, trauma, racism, and other forms of oppression. I appreciate this opportunity to testify regarding the Health Professional Licensing Board's Residency Requirement Amendment Act of 2023. This proposed legislation increases the functionality and representation of the professional boards related to behavioral health care. Licensing boards have a critical role to play in the national and local mental health crisis. Many of the programs the district has invested in require a licensed professional behavioral health specialist, including school-based behavioral health, Healthy Steps, and Healthy Futures. Unfortunately, these district programs and others continue to face staffing challenges, which have delayed expansion and impede access to services. It is therefore important that the district makes strategic decisions designed to expand DC's behavioral health care workforce. One such investment is for the district to ensure adequate staffing at DC Health to process professional license applications in a timelier manner. The boards must also fill vacant seats, ensure quorums at meetings, engage meaningfully with professionals in the field, and address complex workforce challenges. We have urged that the boards are responsible not just for gatekeeping, but for maintaining an adequate network of behavioral health professionals as a matter of patient safety. The Health Boards Residency Act amends the residency requirements for board seats so that only 50% of the seats held by professional members of the health professional licensing boards are district residents. Allowing professionals who do not reside in DC to serve on their respective boards would reflect the reality of practice in our jurisdiction, as well as the diversity of patients who seek services at the district's institutions. Additionally, we hope that new membership will reinvigorate the boards for the important work ahead of them to maintain an adequate and qualified workforce. This includes the boards engaging in strategic workforce development activities. As the government considers improvements to professional board functioning, we recommend that they explicitly encompass workforce development and remediation of obstacles to licensure as part of their missions. Further, we recommend that the Department of Behavioral Health and DC Health collaboratively establish a data collection approach. This could be done in part through data collected during the licensure process. To truly and effectively address workforce shortages and plan for the future, we need to understand the current workforce. While some behavioral health workforce data is currently collected at the time of license renewal application, it is not published publicly, and it is insufficient to measure the adequacy of the behavioral health workforce, especially those serving children. Without a systematic collection of comprehensive workforce data, opportunities to make informed decisions regarding workforce development are limited. Additionally, an assessment of the current workforce makeup is needed to determine gaps and inform policy and financing decisions. The data should be used to develop and then evaluate behavioral health workforce recruitment and retention strategies. Ensuring the behavioral health workforce is strong and sustainable will improve the safety and well-being of people with behavioral health needs in our community. In addition to the changes to residency requirements, we ask the professional boards in behavioral health to engage robust strategic workforce development activities. Through these efforts, with increased data collection and analysis, the boards can help create a more inclusive, diverse behavioral health workforce in DC. This starts with ensuring the professional licensed boards are staffed and prepared to do this important work. Thank you for the opportunity to testify today, and I welcome any questions.
Thank you. Ms. Millar?
Good morning, Chairperson Henderson and members and staff of the Committee on Health. Thank you for the opportunity to testify today on Bill 25-312, the Health Professional Licensing Board's Residency Requirement Amendment Act of 2023. I'm Melissa Millar, Policy Director for ZEDIC DC, headquartered at UDC. ZEDIC DC's mission is to safeguard the legal rights and financial health of DC residents with low incomes dealing with the often devastating consequences of abusive debt collection practices and other consumer-related issues. We carry out our mission with the goal of addressing racial gaps in wealth and equity and offer direct legal and financial counseling services at no cost to DC residents within 400% of federal poverty guidelines. This bill would reduce the number of required DC resident health professional board members, require that health professional board members be licensed for the regulated occupation and have been engaged in the practice of the board's regulated occupation for 3 years preceding their appointment, require that non-district resident health professional board members be engaged in the practice of the regulated occupation while serving on the board, and require that the board chair and consumer members be district residents. We support expanding opportunities for health professionals to serve their profession and their colleagues through board service and offer the following comments for council to consider. In the statement of introduction for the legislation, it noted that several DC health licensing boards oversee only a fraction of license holders who are also district residents. The memo listed 19 boards that each had no more than 40% district residents under its purview, with a district resident licensee average across 19 boards of only 19%. Each of the district's health professional boards have different application and documentation processes, but by law, DC Code Section 47-2862 prohibits the issuance of any licenses or permits by the district government if the applicant, among other things, owes the district more than $100 in past due taxes or more than $100 in outstanding fines, penalties, or interest. This application of the district's Clean Hands Law to health professional licensing specifically prevents people with debts of over $100 from being able to practice in the district. In fact, the district may now be finding itself with the need to expand board service to non-residents, in part because it limits DC residents' access to occupational licenses if they owe the DC government small debts, preventing them from practicing, and thus being able to meet the 3-year active service requirement. At ZEDIC DC, we have been seeking to reform the Clean Hands Law as it applies to people seeking to access work and business opportunities. In recent weeks, the district has stopped applying the Clean Hands Law to the obtaining and renewal of driver's license, a change that will have positive impact on ZEDIC DC's clients and tens of thousands of other district residents, enabling them to once again have access to vehicles to take them to jobs, take their children to daycare and school, and live fuller lives. Yet ZEDIC DC has other clients who continue to be prevented from becoming licensed in the district in occupations, including health occupations, due solely to debts owed to DC government. One particular client is a district resident who is fully licensed speech language pathologist who provides services in both Maryland and Virginia. However, she's unable to be licensed in the district and provide services to her community in Ward 7 due solely to debts owed to the DC government. We note that the DC Health chart provided in the statement of introduction listed the Board of Audiology and Speech Language Pathology as having only 31% of its overall licensees as district residents. Here, a willing and able practitioner remains unable to provide much needed services to her community, instead needing to leave her home jurisdiction for more favorable licensing conditions elsewhere to provide services to their communities. But for Clean Hands, our client would be providing speech language pathology services to communities east of the river and throughout the district. And for others who find themselves in the same circumstances as our client, the changes proposed by this bill will not afford them any additional opportunity to practice or to serve. Being denied the right to practice today due to debt subject to Clean Hands means that the clock cannot toll the 3 required years of in-district practice required for board service. While the DC Code clearly gives the district government the authority to deny the issuance of a license for a debt owed, the bill is effectively favoring out-of-jurisdiction practitioners who have paid their debts to the district over district residents who are unable to pay their debts. We recommend the committee consider revising the Clean Hands Law, DC Code Section 47-2861 et sec, to prevent the type of disqualification experienced by our client and likely countless other qualified district residents. The district is the only jurisdiction in the greater DC region to automatically disqualify individuals from obtaining occupational and small business licenses due to small unpaid debts like parking and traffic tickets. And as a result, our resident practitioners are providing services to Marylanders and Virginians and not district residents. We applaud the intent of this bill before the committee today, but believe the true solution to this problem is eliminating the Clean Hands prohibition on licensing of our health professionals. Thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you. Mr. Gallagher?
Good morning, Chairwoman Henderson. Thank you for the opportunity to testify today, and thank you for introducing this legislation to reform the process of appointments to health professional boards. I'm Kurt Gallagher, Executive Director of the DC Dental Society. I'm here testifying on behalf of our more than 400 dentist members who are members of the DC community. I would like to offer a number of suggestions for consideration that we believe would strengthen the impact and effectiveness of the bill. First of all, I'd like to recommend that the provisions of Section B1 be expanded to establish a minimum threshold for board members designated for professional members that are, quote, engaged in the practice of the health occupation. Currently, the requirement that be engaged is limited only to non-residents of DC. We believe that this would benefit the boards and the community if this were applied to all appointees. For example, the legislation could require that 75% of all board positions be designated for professional members who are engaged in the practice of the health occupation. A minimum threshold would help to ensure that board members have an understanding of the state of the profession, as well as the practical challenges that health professionals face on a daily basis while attempting to work and provide care to the DC community. In addition, the legislation should clarify what is meant by, quote, engaged in the practice of health occupation. For example, is it sufficient that the appointee simply hold a license, or should the professional be actively practicing or teaching? We believe that the large majority of board members should be actively practicing, not simply hold an active license. In addition, clarity should be provided regarding what qualifies as actively practicing. On a related point, with respect to the board members who currently primarily or exclusively work in academia, we recommend that a threshold be established to limit the number of board members who come from academia. Such a threshold would advance diversity of experience and knowledge on boards and ensure that the board members have practical knowledge of current situations in the community. Health professions change rapidly, a pace that was accelerated as a result of the COVID-19 pandemic. And speaking for dental practices, the circumstances and challenges that dental practices face today are significantly different from just a few years ago before the pandemic. As I've testified before this committee in the past, dental practices are struggling to secure staff, which limits their ability to provide care to the public and limits access to dental care. And when they find staff they want to hire, frequently DC dentists find that their staff face long delays in securing a license to practice in DC. Of the dentists who serve on the Board of Dentistry, none currently work in private practice. The Board of Dentistry has 5 positions, one of which has been vacant for more than 1 year. A private practice dentist was nominated to fill that vacancy last year, but I understand the vacancy has not been confirmed. Of the 4 dentists currently serving on the board, we understand that 3 are retired, and 2 of those actually worked in academia primarily or exclusively for their career. The 4th practices in Maryland. So again, those who serve on the Board of Dentistry collectively have no firsthand knowledge of the circumstances that dental practices face in DC today, particularly the challenges related to licensing and securing staff. In addition, I'm aware of multiple DC dentists who have applied for board seats over the past year, but have not been contacted by the Mayor's Office of Talent and Appointments. The dentists have decades of experience caring for the DC community, and I hope that these dentists who have advanced themselves as candidates will be given fair consideration. We ask this committee to exercise its oversight authority to gain a better understanding of the process that MOTA follows to evaluate candidates for open board seats. Thank you for considering our recommendations and concerns, and I'd be happy to answer any questions you may have.
Thank you. And finally, we'll have Dr. Floyd, who will be speaking specifically about the Ambulatory Surgical Facility Amendment Act. Dr. Floyd?
Yes, sorry, I am trying to navigate 2 meetings. I'm trying to jump off of one and onto the next. Good morning, everyone. Thank you, Chairperson Henderson and members of the committee for the opportunity to provide testimony on this important legislation. My name, again, is Dr. Serena Floyd, and I am the Chief Medical Officer at Planned Parenthood of Metropolitan Washington, D.C. I'm a board-certified OBGYN and have been providing reproductive health care for over 20 years. I have an MPH in maternal and child health from the School of Public Health at the University of North Carolina at Chapel Hill. I'm chair of the American College of Obstetricians and Gynecologists Committee on Healthcare for Underserved Women, and I'm also chair of the National Medical Committee of Planned Parenthood Federation of America. PPMW is a longstanding provider of reproductive health care, including abortion, and annually provides healthcare services to nearly 30,000 patients in the DC area. I am testifying today regarding Bill 25-0073, the Ambulatory Surgery Facility Amendment Act of 2023. To provide language for an amendment that PPMW would like to see added to the bill that would further clarify which procedures would be deemed surgery under Section 44-501 of the general laws. PPMW requests that the generally non-invasive procedures exception to the surgery definition explicitly state that this exception includes abortion and other similarly low-risk procedures. Currently, the definition of surgery in the bill is broad enough that it could potentially include a number of procedures that do not necessarily qualify as surgery and that can safely be performed in health centers that are not designated ambulatory surgical facilities. For instance, the current definition of surgery could be interpreted to include a loop electrosurgical excision procedure, also known as a LEEP procedure, as well as procedural abortion. If this bill passes in its current form, we are concerned that these procedures may be deemed surgery and could be subject to inappropriate heightened regulation. We do not believe that this legislation is intended to conflate these low-risk procedures with other procedures more commonly considered surgical. While there is an exception in the legislation that exempts generally non-invasive procedures from the definition of surgery, we believe it would be helpful to make it more explicit that abortion and similarly low-risk procedures such as LEEP are included in that exception. Abortion and LEEP are safe and non-invasive procedures that do not require the heightened environmental controls of an ambulatory surgical facility, and there is no medical need for them to be provided in an ASF. In fact, today, these procedures are regularly and safely provided in non-ASF settings in the District, Maryland, Virginia, and numerous other states across the country. These procedures, like colonoscopies and endoscopies, are non-invasive because the use of instruments does not require incisions into the body. As a result, these procedures do not call for heightened environmental controls for them to be provided safely. Historically, abortion providers throughout the U.S. have been subject to overly burdensome facilities restrictions that unnecessarily limit patients' access to care. And in fact, before last year's Supreme Court decision in Dobbs v. Jackson Women's Health Organization, anti-abortion legislatures, which could not outright ban abortion due to the federal constitutional protections under Roe v. Wade, often use requirements that abortion be provided in ASFs to limit access to the procedure. In the district, we have been working to make abortion as accessible as possible, leaving open the possibility that procedural abortions could be subject to the same regulations as surgeries, which are higher risk and much more invasive, would run counter to those efforts. So we are asking for the following language to be added in section 13AB. Generally non-invasive procedures, including but not limited to abortion, colonoscopies, biopsies, and endoscopies. Chairperson Henderson, we would be happy to work further with your office on the details of this language. And at this time, I thank you very much for the opportunity to provide testimony and for your consideration of our request.
Thank you. And thank you to this full panel of witnesses, Dr. Floyd, excuse me. I know that you are navigating 2 meetings. So I want to say we're certainly happy to work with you on the language. I don't believe it was the intent. This legislation came from the mayor's office. I don't believe it was the intent to add any additional burdens in terms of some of the procedures that you mentioned, right? Colonoscopies, et cetera. I'm sure we can work something out as we move forward on that front. So
thank you.
Thank you for flagging and raising that particular issue. To our other 3 public witnesses, thank you so much for your testimony. Mr. Gallagher, we have seen you before. And so I think you raise an interesting point. I'll ask DC Health about this, but my guess is that given what we know, some of the time commitment is for some of our more active boards, perhaps some of our, although licensed, but yet retired physicians in these areas find more time to be able to participate in this. But frankly, I think we need to do a lot more work in terms of trying to recruit. And it's just sort of an understanding. We think that this is just one step to helping the whole, and we couldn't wait for the full health professional licensing Amendment Act revisions. We felt like we needed to move on this. For the public, just to give you some numbers in terms of what we're talking about here. So the board of, let's take one of our 19 boards. So the Board of Podiatry has 145 licensed physicians in the district. Well, has a total of 145 licensed physicians here in the district. 8% of those are district residents. So if y'all pull out your calculator, some of you are math whiz, that's 11 people. We only have 11 people to choose from for the licensing board for the Board of Podiatry. The Board of Respiratory Care has 678 folks, only 11% of whom are DC residents. So that's 74 people. So it really limits our ability to to recruit folks who want to give up their time. And just a reminder for folks, like these are unpaid positions. So you are giving of your time and your service and to advance your profession, to provide some guidance to your profession here in the district. But we just feel like it might be a little bit more restrictive. Ms. Millar, I appreciate you being here. I will say the idea of getting rid of clean hands for serving on a board who has responsibilities in terms of discipline and others gives me pause, frankly, because I don't want to set up an incentive by which someone can be bribed. And I think that could be one of them in terms of, I just said, we're not paying anybody. So if folks know that you have a particular debt, and I'm not talking parking tickets, in many of these cases, we're talking taxes as well. We just don't want to set up that particular situation. But your organization has done great advocacy in the past on some of the clean hands issues. And so I'll ask DC Health about this, but I imagine this might not be the vehicle for that particular advancement of policy. But thank you again to everyone who testified. We are going to turn to our government witnesses and move right along. So thank you all. Okay, so what we're going to do is 2 at a time so that everybody doesn't have to stay here for all of the bills for which you don't necessarily have skin in the game for. Well, we all have skin in the game, but statement for. So we're going to start with Tia Brumstead, who is the Assistant Superintendent for OSSE, the Office of State Superintendent of Education. And then we will have Robin Diggs Purdue, who's the Interim Senior Deputy Director of Community Health Administration for DC Health. And then we will do the other 2 after we wrap with them. Okay, before you all begin, yeah, I have to swear you in under oath. So if you all can raise your right hands. Do you swear or affirm under penalty of law that the testimony you're about to provide to the committee, to this committee and the Council of the District of Columbia is the truth, the whole truth, and nothing but the truth? Great. All right. So we'll start with Ms. Brumstead. If you can just turn on your mic and present your testimony.
Thank you. And good morning, Chairwoman Henderson, members of the Committee on Health and staff. My name is Tia Marie Brumstead, and I am the Assistant Superintendent of Health and Wellness at the Office of the State Superintendent of Education. And I welcome this opportunity today to discuss Bill 25-226, the Access to Emergency Albuterol and Glucagon Amendment Act of 2023. OSSE sets academic standards, builds educator capacity, monitors federal grant programs, and develops systems for accountability. At OSSE's Division of Health and Wellness, we set district policies and provide technical assistance to schools and local education agencies to promote student health and wellness, with a special focus on health and physical education, student nutrition, environmental literacy, school gardens, farm-to-school programs, and educator wellness. We also work closely with the Department of Behavioral Health to promote student mental and behavioral health, and with DC Health to coordinate student immunization policies and limit the spread of infectious diseases in schools, including COVID-19. OSSE recognizes that asthma, diabetes, and other chronic health conditions and diseases can pose significant barriers to student health and wellness, as well as school attendance and academic achievement. Currently, school nurses and health staff suite are responsible in coordination with a student's family and physician for addressing such chronic health needs while in school. DC Health School Health Services Program and Children's School Services provide schools with approved health suite staff, a combination of registered nurses and health technicians. In addition to assisting students referred to the health suite, these staff provide services for students with special healthcare needs. This may include the administration of medication, treatment administration, monitoring chronic health conditions, coordination of care, and the development of an individualized health plan. Schools may also identify other school staff trained in the administration of medication and basic first aid to assist in the case of emergencies. When medication needs to be administered during the school day, the student's parent or guardian is responsible for providing the medication to the school and for completing the necessary school health forms in consultation with the student's physician. Health suite staff and school staff then coordinate to ensure student health needs are met during the school day and how to respond in the event of a medical emergency. District schools are currently provided with 2 undesignated medications to use during medical emergencies, naloxone and epinephrine. This year, DBH began distributing free undesignated naloxone to participating schools and training school staff and health suite staff on its use for medical emergencies. DBH, in coordination with local education agencies, DC Health, OSSE, proactively determined that life-saving naloxone is essential to immediately respond to individuals experiencing an opioid overdose on school grounds. Additionally, beginning in 2016, all public and public charter schools began annually receiving 4 free undesignated epinephrine autoinjectors, or EpiPens, for students who unexpectedly experience anaphylaxis while at school. OSSE provides training on properly administering and storing EpiPens and coordinates annually with an area physician to secure a standing medical order for epinephrine. The EpiPens are provided to district schools and schools across the country through the National EpiPen for Schools program, which is paid for and managed by BioRidge Pharma and Viatris Inc. While we support the goal of the legislation to enable schools to access and administer undesignated albuterol and glucagon in the case of medical emergency, in its current form, the legislation fails to account for key operational challenges that schools and the district will face. The challenges of supplying and administering albuterol and glucagon are very different from the operational demands of the EpiPen program. While OSSE successfully manages the epinephrine portfolio, the costs and logistics associated with purchasing, storing, shipping, and replenishing EpiPens are all provided free of charge by the National EpiPen for Schools program. A similar program does not currently exist for free albuterol and glucagon in schools. Furthermore, the legislation places healthcare provider responsibilities on OSSE that are outside of our current capabilities to execute and our role as a state education agency. OSSE does not have medical providers on staff, and the guidance, training, technical assistance that we provide on epinephrine has taken years to refine after repeated and targeted engagement with our area healthcare providers and with national partners like the Food Allergy Research and Education. Medication procurement, storage, training, and administration are not generally a responsibility of the state education agency. The albuterol and glucagon portfolio may be better suited if integrated within existing health suite structures and administration of medication training rather than developing a parallel track at OSSE. For example, glucagon is typically only administered to students diagnosed with diabetes in the event of confirmed low blood sugar and severe hypoglycemia. As such, health suite personnel would be best positioned to determine the need to supply and administer undesignated glucagon based on student health needs. This data-informed approach would be preferred to distributing glucagon to all schools and requiring all schools to have staff trained on its administration. Moreover, as guidance from medication administration in schools continues to change over time, details concerning the use of albuterol, glucagon, and other emergency medications in schools would be better addressed through health regulations and guidance rather than law. This could include adding new undesignated medications or redefining medications and regulation as they evolve over time rather than revisiting the law each time. For example, the current draft bill defines glucagon as a drug delivery system with a spring-activated needle. However, there is a form of glucagon that can be administered as a nasal powder that might be more appropriate for administering at school. So as such, we support DC Health's ability to determine which medications can be administered in emergency circumstances and how they can be administered, and doing this through regulation. OSSE remains committed to working with DC Health, our local education agencies, and area health partners to ensure student health and wellness needs are met while in school. And we look forward to continued collaboration with council and our partner agencies to ensure that school communities have adequate access to life-saving medications. Thank you for this opportunity to testify on Bill 25-226, and I welcome your questions.
Thank you, Ms. Brumstead. Ms. Purdue?
Good morning, Chairwoman Henderson, council members, and Committee on Health staff. My name is Robin Diggs Purdue, and I'm the Interim Senior Deputy Director for the Community Health Administration. Can you hear me? Okay. Oh, sorry. My name is Robin Diggs Purdue, and I'm the Interim Senior Deputy Director for the Community of Health Administration, also known as CHA, at the District of Columbia Department of Health, or DC Health. On behalf of Mr. Keith Fletcher, Interim Director of DC Health, I'm providing testimony on the Access to Emergency Albuterol and Glucagon Amendment Act of 2023, which would expand access to certain emergency medications for our students in the district's public schools. We strongly support the aim of the act, but believe there are some operational considerations that must be addressed before such a law can be implemented. DC Health School Health Services Program supports policies, processes, and programs that improve the health of students, enabling them to thrive in the classroom and beyond by creating greater alignment, integration, and collaboration between education and health. This program supports over 80,000 students in over 200 different schools through our grantee Children's School Services, or CSS, which provides nursing services and ensures children have their medical needs met so they can learn and thrive in school. DC Health manages CSS to ensure they have the resources and policies in place so that they can support our students. There are several common medical conditions that can pose a serious health risk to our children, as well as cause them to struggle in school. Two key drivers of absenteeism and interrupted learning are asthma and diabetes. Undiagnosed or untreated, these conditions can cause dangerous complications, chronic absenteeism, challenges with quality of life, and preventable emergency room visits and hospitalizations. According to the district's behavioral risk factor surveillance system, 12.8% of children in the district had asthma in 2020. Research estimates that less than 0.1% of our children had type 1 diabetes as of 2016. While population level data is important to understanding the overall disease burden of asthma and diabetes on our community, our school health program also collects data from district public schools that use our electronic school health record system to track student-specific prevalence of these two diseases. In the most recent school year, we identified 12,338 students in district public schools who had an asthma diagnosis. While this is comprehensive of most public schools, there may also be additional students in charter schools who do not currently use our EHR who also have a diagnosis of asthma. Recognizing that this data may be a slight undercount, we estimate that at least 13% of district public school students in the 2022-2023 school year had a documented diagnosis of asthma. Far fewer students have documented diabetes diagnoses. As of May of this year, there were 219 students in our EHR with diabetes. This may be an undercount for the same reasons I previously mentioned, yet would indicate that less than 1% of students have a documented diagnosis of diabetes. The impact of these health conditions is significant. Our school health services program has documented 2,395 asthma-related visits to health suites, and in 47 of those instances, emergency medical services were called. There were also 837 diabetic-related visits to the health suite, and in one instance, EMS was called. Thankfully, we have an opportunity through policy and program enhancements to improve the management of these conditions with pharmacological tools that are highly effective at managing and preventing complications from asthma and diabetes. Albuterol is a common medication prescribed to people with asthma that can treat a frightening and serious tightening of muscles around the airways, or bronchospasm. This medicine is administered with a spacer, which is a small cylinder that allows the individual to fully inhale the medication and then absorb it into the lungs. Almost all children diagnosed with asthma will have been prescribed albuterol, and most will carry it, even if they never use it. However, in accordance with the Student Access to Treatment Act, or SATA, medication may only be administered to students who have a medication action plan on file with their school's health suite. For asthma, this is called an asthma action plan, or AAP. And only 19.1% of the students diagnosed with asthma have an asthma action plan on file at their school's health suite currently. For students with diabetes, insulin is often carried to address hyperglycemia, or high blood glucose levels that occur with this disease. Sometimes treatments for diabetes can drop the blood glucose level too low, called hypoglycemia. This can be life-threatening and is often treated with the medication glucagon. Unfortunately, the risks of hypoglycemia are not always recognized, and students often do not bring glucagon prescriptions to school. Until recently, glucagon was only available as an injectable, but a nasal spray was recently developed for individuals 4 years of age and above, which is equally effective and easier to use. A child or a responsible adult can administer this medication easily and safely. With the medication, blood glucose concentration levels begin to rise within 15 minutes, effectively treating hypoglycemia. As with asthma medication, students must have a diabetes care plan on file at their school's health suite, but only 55.3% of students diagnosed with diabetes have a care plan on file with their health suite currently. To address the challenge for students who lack needed medication, DC Health has been working with CSS and our provider community to reduce barriers to the submission of medication action plans. We are working to enable a provider portal for electronic completion and submission of the Universal Health Certificate and asthma action plans in the short term, while simultaneously working towards a longer-term solution to directly connect the major pediatric provider EHRs to our DC Health provider portal and enable automated asthma action plan and Universal Health Certificate submission. This will reduce delays in paperwork submission and ensure that needed medication is accurately documented in the school's EHR system. However, we recognize that even if our efforts are entirely successful and all diagnosed children have a medication action plan on file, there will be times where a student may not have or carry their needed medication. In those instances, undesignated medication can reduce an adverse health outcome for a child, as well as limit the time a child is away from class. There are only 15 states that explicitly allow schools to administer undesignated albuterol, including Virginia. Of note, most allow for undesignated albuterol without requiring it, since states recognize the challenge and burdens this can place on individual school districts. Requiring glucagon is even less common, and we are aware of only 2 states currently allowing undesignated glucagon, which are Illinois and Ohio. In initial conversations with these states, they were unable to identify school districts that had fully taken advantage of undesignated glucagon because of operational challenges. Those challenges include the purchase, transportation, and storage of the medication. It also includes oversight of schools for compliance and training and the procurement of a standing order. While none of these are insurmountable by themselves, they will take significant planning and engagement with our education sector partners. However, we believe that there's a significant benefit to students should these operational challenges be addressed. We will spend the next few months working with our counterparts at OSSE, DCPS, DCPCS, as well as CSS to identify possible solutions and costs to administering this law. In addition, we believe that albuterol serves a purpose in all schools, but glucagon is most useful in schools with students diagnosed with diabetes. as it often is used by students who are also using insulin. Therefore, we believe the use of these undesignated medications will be different and require a different tailored approach. While we appreciate council identifying specific medications to add to statute, we believe it is far more effective to allow DC Health clinicians to designate which medication should be added to SATA for emergency use. For example, in this legislation, the glucagon is indicated to be the injectable type. However, the nasal spray version is easier to administer and shelf stable across a wider temperature range. With more flexibility, DC Health can identify through rulemaking the version of specific medications that are most effective and feasible to store at schools. Additionally, treatment protocols and medications can change over time, sometimes very quickly. As modifying statute is a time-consuming process, we believe that a better path than designating specific medications by statute would be to give DC Health the regulatory authority to define, add, and remove medications by rulemaking. This would allow us to easily add other medication, such as naloxone, tailor specific medications to specific schools, such as glucagon for schools with students with diabetes, and manage the rollout of each medication as necessary based on need, safety, cost, and feasibility. I want to thank the council for allowing DC Health to share feedback on this legislation and recommendations on how to better address the unmet medical needs of district's public students. I look forward to working together on future legislation to update the district's Student Access to Treatment Act, and I'm available for any questions. Thank you.
Thank you. And I think we've been joined by my colleague from Ward 5, Councilmember Parker. Councilmember Parker, we'll do a 10-minute rounds if that's cool with you. Okay, great. So thank you so much, both of you, for your testimony. I will say, I told my staff I have like battle scars on this because when we did EpiPens, I was the committee director for the Committee on Education. And it ended up at OSSE because DC Health didn't want to do it. And so here we are. Now we're back. And OSSE's like, no, it's not us. It should be at DC Health. But also I appreciate sort of the dialogue around how we can better streamline the processes altogether, because it was news to me that we have 3 different agencies who are doing medication administration training when the larger administration of medical training could cover all of these various pieces and things. But let me ask a couple of questions for clarification, because we're going to have to establish a record a little bit here. Okay, so Ms. Perdue, you stated that 55% of students who have diabetes have a diabetes action plan on file. That's lower than the number that we had earlier this year. Is that reflecting going into school year 23-24, or is this from the end of school year 22-23?
That's as of May of this year.
Okay, so as of May of this year. All right, so we have some work to do before we get to August.
Yes.
Yeah. And I was
Yes.
like, when does school start? Very soon. Okay. Also, I just want to clarify some of the numbers too. You said in your in DC Health's EHR electronic health record system that you all have 219 I guess public school students who have diabetes on record. But there were 837 visits. So either somebody was going multiple times, or there were children who you didn't have on record of having diabetes who were visiting the health suite. Which happened? Or do you guys kind of know?
We'll look into that, but usually it's multiple visits by those children who are on file for having diabetes and for asthma.
Okay, so I guess for additional clarification for me, the student that you have in your EHR record may not have an action plan too.
So, right. So for example, it could be indicated on the UHC that a child has asthma or diabetes. But
Okay.
they don't actually have the medication action plan or care plan, which is a separate form that needs to be completed and submitted.
Okay, we should probably dig in a little bit there, because that seems a little high to me. If we're having the same students who are coming to the nurse's office time and time again, perhaps there's something else that needs to be happening there
Yes.
in terms of the primary care physician and doing that work.
Absolutely.
All right. So Ms. Brumstead, one of the operational challenges that you sort of mentioned was that this is very different than EpiPens because there's an organization that kind of handles it for EpiPens. So what is OSSE's role outside of training as it pertains to the EpiPen program?
Thank you for the question. So OSSE's role is to ensure that our schools are aware of the law and that our schools have the designated points of contact, which includes having an epinephrine liaison and then at least 2 staff that are certified as epinephrine administrators. And then we continue to support those staff and their roles under law, which include the monthly checks of supplies, the logs, ensuring that that each of our schools submit an annual epinephrine emergency plan for the undesignated epinephrines in our school system, and that any time that they are having to utilize one of the undesignated EpiPens, that they are then submitting an incident report, which our staff review in consultation with the physician that provides the standing order to provide any feedback guidance that might be necessary and to ensure that we do an immediate replenishment for the EpiPen that was used.
Okay.
And that also includes monitoring the expiration dates to make sure within 4 months of expiration, the liaison is letting us know and that we are able to coordinate the replenished stock, which then the national organization procures and ships directly to the schools.
Okay. So the OSSE is basically like, you're the logistics.
So the logistics, the auditor, the TA provider. Yes.
Okay. And so is this something that OSSE wants to continue doing?
We believe that this program is exceptionally important and we appreciate.
No. That's not what I'm saying. Should you all continue to do this? Because I guess one of my questions would be is how many of the people who have been trained in EpiPen administration are also just already trained for administration of medication?
There is some overlap. However, we do have some folks who are not AOM trained. There's a significant investment in AOM training,
right?
And it's much more broad than just EpiPens. So we are committed to working with DC Health to look at the training portfolios for all 4 of these undesignated emergency medications to determine a way that we could streamline this for our staff.
Okay. Everybody at the table together. This is great for a good conversation, but I would hope that over the next few months, you all can talk with DC Health around whether or not it makes sense for OSSE to continue to be the point person on the EpiPen program if we're talking about administration of medication and all of those other things being with DC Health. Just something to consider while we're here opening this up. But you bring up another point, which was a sticking point on EpiPens. Who does the standing order for said undesignated items? So OSSE coordinates now for a physician to do it for EpiPens.
So DC Health supported us with identifying a physician to provide the standing medical order for the EpiPen program. That physician was identified in 2016 and has graciously stayed with us and is continuing to practice. And so we have not had any challenges with this particular program, but that is a real challenge.
Okay.
Should we need a new provider to provide a standing medical order.
Ms. Purdue.
Yes, it is a private physician.
Okay.
Which is authorized. It could also be a nurse practitioner, but we would have to identify who that could be.
Okay, so the public health agency can't be why can't DC Health administer the standing order?
I mean, that's an option. That is an option.
Okay.
Yeah.
We'll leave that out there as an option piece. Okay. In terms of, I heard your feedback in terms of your testimony around us, number one, the wisdom of providing the flexibility to DC Health to sort of make the determination around what is the medication that is best suited for whatever the particular need is. And then also heard you very clearly around the perhaps treating albuterol and glucagon very differently, given that many students who might experience hypoglycemia have already been designated as, or already have a diagnosis for diabetes, whereas with asthma, it can pop at any point in terms of what happens with a student there. So should we then amend the legislation to provide DC Health with the authority to make decisions on all undesignated medications that are made available in schools?
I mean, we think that it would make sense. We would prefer that we would have that option and be able to streamline which medications are appropriate for emergency use through the rulemaking.
Okay.
And so also like naloxone is currently not required, right? But it's allowed. So we could also add naloxone to the rulemaking as well, and consider if there's any other medications that would be appropriate to add.
Do you all do reporting out of, obviously we see reporting around undesignated EpiPens. DBH has reporting, I believe, on Narcan, or that's required for schools, I think. If naloxone is administered at a school, they have to report to someone. Is that accurate, Ms. Brumstead? Or
There's a tracking system.
There's a tracking
that we
system.
use for incidents. Yeah, an incident reporting system.
okay, so that would be the same here, right? If a school were to use albuterol, they would need to report that somewhere.
Right.
With undesignated albuterol, and I'm sorry if I'm going outside of your main scope of expertise, but I know for EpiPens, you still have to call FIMS when that is administered. Do you still need to call FIMS when albuterol or glucagon is also administered as well?
For glucagon, yes, not necessarily for albuterol, but for glucagon, yes.
Okay, because I think that would be the question around like making sure we have those additional safeguards in place, but also some medical professional to explain to the parent, A, what happened, and B, here's the follow-up of like going to see a physician and really getting an action plan on file.
Right.
But I don't have enough time to get off another question. Councilmember Parker?
Thank you, and thank you all for your testimony. I'm going to start with you, Ms. Perdue. I just want to make sure I got some of the stats right. You were saying on average about 219 students have or are on record as having diabetes within our schools, which accounts for less than 1%. And I forgot, or I didn't catch the specific number, but over 3,000 or so students within our schools have a documented case of asthma, which therefore you're suggesting we should treat the medications available within our schools very differently. Did I capture that correctly?
It was over 12,000 for asthma.
12,000, got it. But the gist there is you're saying the availability of medications should be treated differently. That, in other words, it should be a case-by-case basis for medications for diabetes, given that we have such a small fraction of our students that are grappling with that disease.
It's also the nature of the disease and the medication itself, right? So typically insulin itself, the administration of insulin can actually cause the hypoglycemia event for the child, right? So that's why it's like a side effect that can occur when you're receiving the treatment for diabetes. So therefore the glucagon is needed to then raise your blood glucose levels up back to a normal level.
I got you. And then in terms of the health plans, am I to understand that if a student doesn't have a documented health plan on file, and I believe the number you gave was only 55% of students have a health plan on file, that they cannot receive treatment at a school site?
Yeah, it was 55% for diabetes and 19% for asthma.
But without that plan, is it accurate that they cannot receive treatment at a school site?
Right. So currently when that occurs, EMS just has to be called.
And DC Health is working on an electronic portal, which I imagine will make this documentation easier. That that also just made me think of a process of the documentation. Can you just quickly walk me through what are the steps for creating a health plan for a student? that I imagine a parent would have to get a doctor to sign off, and there would need to be some documentation with DC Health?
That's correct. So there's the Universal Health Certificate as well as an asthma action plan or diabetes care plan. All three must be certified by a healthcare provider. And typically the parent would submit that to the school nurse each year. But if it's paper form, like especially with our some of our charter schools that are not part of the school health services program, if we're relying on paper, it gets, it's not getting where it needs to go. And so being able to allow providers to electronically submit that to us, we expect will drastically increase the rate of documented records that we have on file, and will allow for the school health suite staff to provide better care.
I got you. One of the things I was thinking about with the suggestion that we should have a more tailored distribution of the glucagon, given that there's such a small fraction of students dealing with diabetes, is that we know a lot of our students are transferring in between schools, and given the lag time that we're talking about, I would worry if how many students would, for the lack of a better phrase, fall through the cracks, or would be their paperwork would still be in shuffle in the instance that they have an emergency at school. Just throwing that out there as a concern.
Yeah.
Ms. Brumstead,
one thing that we will be discussing and considering is whether it would be more appropriate to limit glucagon to schools where there is a diabetes care plan on file, or whether it's just appropriate to have it where there's a diagnosis of diabetes on file. So it's two different things, right? You can have a documentation of diabetes, but not necessarily the diabetes care plan. So those will be options that we're exploring as well.
And in that instance, if you have a documented case of diabetes, but not the care plan, in the instance of an emergency, the school would have to call an EMS based on our earlier conversation.
Well, currently, right. But under the proposed legislation, it would allow for the glucagon to be administered if that child with known diabetes is demonstrating symptoms of hypoglycemia.
Right. I'm aware of that.
And still EMS will be called for follow-up, right? Just like with EpiPens.
But I thought your testimony was pushing back on that in some ways.
No, I think our in terms of having glucagon available at all schools, we don't necessarily think that's appropriate. Right?
Got it. And I guess what I'm flagging is if that student with or without a care plan that has a case of diabetes transfers from school A to B, and we know that we're still dealing with a paper process for those care plans, there are inevitable lag times where students may not be able to receive care in our current system, and or in a system where there's only a targeted distribution. But I thank you for that. I did want to come to you, Ms. Brumstead. I hear loud and clear that you're sharing that we support the spirit of this legislation, but you're highlighting operational concerns, namely around cost and the management of these medications for schools. And can you just speak more to what would it take with the current language of the legislation for OSSE to adhere to it? Like, what would be some of the operational steps that you would need to take?
Thank you for that question. So operational challenges would include the need for us to have personnel to manage this program full-time. We do have a full-time personnel that have been managing the EpiPen program, and that person is quite busy. We would also need the tech to build out, or the CIO infrastructure to build out the tracking and administration system, similar to what we have with the epinephrine program. In terms of then creating the program and moving it into play, there would need to be a standing medical order. We would have to then go through the contractual and procurement process to procure the medication, identify storage for all of the medication, and then be responsible for the initial distributions or the annual distributions, as well as replenishment stocks, particularly for the glucagon. The spacers might support some of that with not needing to replenish as frequently for the albuterol, but for the glucagon, we would need to.
Okay, that is super helpful. One of the things I'm especially sympathetic to is the storage of the medication. And I would imagine you would need to find a central location, as you're likely not going to do that at every school site before distributing it. And so I don't want to speak on behalf of the committee, but I do think you pose a very compelling point that there is some workarounds that we ought to consider, just given some of the challenges that this would pose to OSSE. In my last, minute or so, you also, Ms. Brumstead, talked about DC Health should be able to determine which medications, and whether that's like through a powder form or otherwise, should be administered. And can you just speak more to that? Like, are there ways that in partnership with DC Health, OSSE could reduce some of the operational challenges you're talking about, namely like the storage and protection of the medications? But what would be the pros and cons of DC Health making certain determinations of which medication to administer at a school site?
There are 3 questions, so I'm going to try to go through.
I know.
That's okay. That's okay.
It's more so the last one. Like, you were recommending giving DC Health the authority to determine which medication is best, which makes a lot of sense.
So I think that sorry.
Yeah, go for it.
There's opportunity for legislation to identify the medical conditions for which we would want to have undesignated medications available, and then provide the authority to DC Health to determine those medications. That would allow our health experts who are already following trends in medical treatment to be able to watch how they evolve over time, and then make recommendations to the education sector about which medications make most sense for schools. I think similarly, when it comes to those operational challenges, and we think about the procurement of medication, this is not the procurement of a COVID test or the procurement of a health education curriculum. This is very different, and we would want to lean on the expertise of our health department to be in charge of that procurement and those decisions, and in terms of what storage looks like for the entire district.
Understood. That is my time. Thank you for your testimony. I think you're giving us a lot to think about. I am going to have to jump to another committee. So Chair Henderson, thank you for this opportunity to ask questions.
Thank you, Councilmember Parker, for being here and for your questions. I just have a couple of follow-ups, and then we'll move on. So Ms. Perdue, you talked about 15 other states, including Virginia, allow for school districts to have undesignated albuterol. When you all, I don't know if you made calls, if you all just did a Google search, but if you talk to some of our neighboring jurisdictions, did they mention anything about the cost associated with operating a program like this?
We've done a little research, and we've estimated the cost to be about $165 per school for 2 rescue inhalers, as well as spacers, and potentially masks, which are helpful for like our littles, our pre-K 3, age students.
You said mask?
Yes, there's a mask that we actually have a.
Oh, look at you guys coming with props.
Yeah, so this is what the mask looks like, and this part is the cylinder, is the spacer.
Ah, that's what we're like.
Yeah, you see, it's pretty small, but for younger kids, the mask is helpful.
Yes. Okay. Okay. So the last question, and we could workshop this a little bit. I think the legislation though required that we do this by July 1st of 2024. My question is, realistically speaking, if we all work together and get all of our ducks in a row, obviously we have to finance this. We'll get there. But is this something that we could realistically do for school year 24-25? So that gives everybody a year.
We think that that's feasible. Obviously for.
I know
glucagon,
caveats around finding someone for a
Yeah.
standing order,
Yeah.
making sure we have the funding
Yeah.
for this, and then also giving time for, I guess, a comment period if there is any sort of regulation or rulemaking that you all need to do.
We do think that's feasible.
Okay. So you all know council's going on recess in a little bit here, but over the summer, I do hope that we can continue talking, but in particular, having OSSE talk more with DC Health around if there should be a transfer on the EpiPen program to DC Health. I'm not saying you'll have to give it up. I'm just saying, let's talk about it. Because I heard Ms. Johnston loud and clear. It can be very confusing, I think, for someone of who to go to for what, even though the administration of medication training does cover everything. Perhaps someone doesn't necessarily want to be trained in all the things, but EpiPens is something that is particular to them. Or, if you had a teacher who realized that they were going to have a student in their class that year who had asthma and they wanted to be trained just to be able to better support their young person in their classroom should a situation arise either at school or on a field trip. We just want to be able to make that flexibility and pieces available. But let me check and see if I have any other questions before you two leave. So hold on one second. All right, so thank you all so much. Before we switch to the next two, we're going to take a 5-minute break and then we'll come back and we'll wrap this up. So thank you so much.
Thank you. Thank you.
All right. We are back for our final two. So we'll have at the table Aisha Nixon, who's the Associate Director of the Office of Health Professional Licensing Boards for DC Health, and Renata Cooper, who is the Associate Director of the Office of Health Facilities in the Health Regulation Licensing Administration at DC Health. I love this, I love Director Fletcher, but I get to see the full array of the agency on display these last couple of weeks. So whoever would like to go first.
Good morning, Chairwoman Henderson, council members, and staff of the Committee on Health. My name is Aisha Nixon, and I am the Associate Director for the Office of Health Professional Licensing Boards within the District of Columbia's Department of Health, DC Health. On behalf of Mr. Keith Fletcher, Interim Director of DC Health, I am pleased to offer testimony on B25-0312, the Health Professional Licensing Board's Residency Requirement Amendment Act of 2023. We appreciate council's support and attention as we work to overcome barriers to identifying and appointing qualified members to the district's health licensing boards. DC Health has 19 health professional licensing boards that oversee over 80,000 licensed health professionals from 72 professions. These board members do the important and time-consuming and uncompensated work of regulating their professions to ensure standards of care are up to date and that patients are protected. They also engage in educational and outreach activities, as well as interprofessional activities across the boards and with DC Health administrations. However, over the past several years, we have seen an increase in retirements and departure of board members due to the pandemic and aging of the workforce. We have also seen fewer interested health professionals approach the boards due to the burnout in health professions, which has required the board members and board staff to do more proactive recruitment. This has resulted in an increase in vacancies, which in turn requires the remaining board members to do more board work with less support from other board members. In addition, the increasingly high turnovers in healthcare professions, particularly nursing, through nursing staffing agencies, has increased the workload of board staff and board members. These challenges have resulted in the current total of 48 vacancies across 18 of our 19 licensing boards. These vacancies are primarily for professional members. We have 33 vacancies for health professionals and 14 for consumer members, as well as 1 vacancy for the director of DC Health's designee. Roughly a third of those health professional member vacancies have identified nominees who are currently in the pipeline between the Mayor's Office on Talent and Appointments, MOTA, and Council's approval and appointments. If those members are seated, we have 23 professional vacancies across all 19 boards and will only have 1 board, the Long-Term Care Administration, who would have more than 2 professional vacancies. That does, however, assume that no other board members will leave or be termed out. We anticipate several departures, as is normal, over the coming months and years. Currently, just under 19% of licensees under the health professional boards are DC residents. The percentage for each board ranges from a high of 39% for the Board of Massage Therapy licensees being district residents to only 8% of the Board of Podiatry licensees being district residents. This presents a significant challenge to identifying and nominating board members since the pool of licensees for those boards is small. This legislation aims to address the above challenges in finding and retaining qualified board members by providing the mayor with increased flexibility in appointing individuals to health licensing boards. Under current statute, all members of licensing boards must be DC residents, regardless of where they engage in the practice of their profession. This legislation will allow up to half of board members to live in another jurisdiction if they are licensed in good standing in the district for at least the preceding 3 years and be engaged in the practice of that health occupation in the district while they are members of the board. However, should the council move forward with this legislation, there are several changes that we believe are necessary for successful implementation while ensuring that all board members are meaningfully connected to the district and district patients. First, we believe that the allowance for up to half of the professional members to residents of jurisdictions beyond the district is arbitrary and may cause confusion. For example, shall a small board of 4 professional members, 2 residents and 2 non-residents suddenly lose 1 resident member? It is unclear if the board would be able to function. We recommend providing the mayor with the flexibility to have non-residents as board members without a number, as it is extremely unlikely that MODA will solicit non-resident members except for when no qualifying or willing district residents are available. Therefore, there should be no concern about a board being made up of primarily non-residents. Second, there must be clarity in what engage in the practice of health occupation in the district means. All non-resident members should have a physical practice or employed physically in the district and should be working at least 20 hours per week, approximately the same amount of required for the part-time participation in our health professional loan repayment program. Third, there should be safeguards to ensure that members do not engage only in telehealth. We believe no board member who does not live in the district should be engaged primarily in telehealth. Finally, there should be some requirements for MODA to audit these non-residents. With a larger pool of individuals, it is important to ensure that all members comply with these requirements. With these 4 clarifications, we believe this bill can still meet its intended purpose while ensuring that the non-resident members are meaningfully connected to the district and our residents. We acknowledge the need for innovative solutions to fill health professional licensing board vacancies and appreciate Council's attention to this important matter. We are also hopeful that our revisions to the Health Occupation Revisions Act that are coming this fall should address some of the board membership concerns, and look forward to continuing this discussion when Council returns from recess. Thank you for providing me with the opportunity to testify, and I am available to respond to any questions the committee may have.
Thank you. Ms. Cooper?
Good morning, Chairwoman Henderson, council members, and the staff for the Committee on Health. My name is Renata Cooper. I'm the Associate Director of the Office of Health Facilities within the District of Columbia, Department of Health, DC Health, Health Regulation and Licensing Administration, PERLA. On behalf of Mr. Keith Fletcher, Interim Director of DC Health, I'm pleased to offer testimony in support of Bill 25-0073, the Ambulatory Surgical Facility Amendment Act of 2023. The district has a robust healthcare system that includes over 80,000 licensed healthcare professionals and hundreds of healthcare facilities. These facilities range in size and scope from large full-service hospitals, including the soon-to-be open Cedar Hill Regional Medical Center, to federally qualified health centers and primary care practices. DC Health plays a critical role in ensuring patient safety by regulating healthcare facilities. This includes inspecting facilities, responding to complaints, conducting investigations, and taking enforcement action to ensure facilities come into compliance with district and federal law. One facility type that is a critical part of the district's healthcare system is the ambulatory surgical facility, further to be referred as ASFs. Under the current definition, ambulatory surgical facilities are locations that perform outpatient surgeries and other related procedures other than hospitals or maternity centers. Within the district, most ASFs provide a variety of healthcare services. The process to become a licensed ASF in the district involves multiple entities within DC Health. It starts with the facility attaining its Certificate of Need, or CON, from the State Health Planning and Development Agency, SHPDA. The CON is an important step in the process, as it demonstrates that the ASF is meeting the health needs of the public where it is seeking to be established. Additionally, the CON process advances health equity by ensuring healthcare costs are reasonable and that the facility is viable to serve the healthcare needs of the community long-term. Once a CON has been attained, ASF applicants go through the Office of Health Facilities where they attain the appropriate license. Part of the license application process involves an inspection by DC Health staff, which focuses on a variety of operational elements, including staffing, policy and procedure reviews, and physical environment inspections. This licensure process ensures that ASFs have met specified licensing requirements and operate within acceptable standards of practice to ensure patient safety. The Ambulatory Surgical Facility Amendment Act of 2023 makes several important changes to the district's Healthcare and Community Residence Facility, Hospice and Home Care Licensure Act of 1983. One of those changes repeals the requirement that the list of procedures that can be exclusively performed at ASFs must be listed through rulemaking. It is currently extremely challenging for DC Health to issue regulations for ASFs due to the difficulties with identifying procedures that can only be performed at an ASF, as most could be performed in other healthcare settings. Instead of this erroneous rulemaking requirement, the legislation adds a statutory definition for the term ambulatory surgery, which would limit post-operative observation to less than 24 hours and cannot require hospital admission after the procedure. Additionally, the legislation adds definitions for the terms operating room, procedure room, and surgery, each of which are important to the overall definition of an ASF. While DC Health is able to regulate ASFs under existing DC Official Code 44-532, this existing statute is out of date and lacks clarity. Removing the requirement that a list of procedures be included in regulations would enable DC Health to adopt new regulations that would allow our agency to provide clearer and more specific guidelines for the scope and operation of ASFs in the district. Importantly, this change would bring the district in line with other states in the region, including Maryland, that also does not specify a list of procedures that are permitted at ASFs, but instead provide clear regulatory guidelines for facility operations. This is especially important given continuous advancements in technology and medical interventions. As a result, DC Health would be able to oversee ASFs in the same manner as other regulated healthcare facilities located both in and outside of the district. The legislation also clarifies the definition of what type of facility constitutes an ASF. The bill clarifies that a dental office is not considered an ASF while maintaining that ASFs cannot be hospitals or maternity centers. Additionally, it affirms that office-based, outpatient, or other facilities that are connected to but physically separated from hospitals can be considered ASFs. These clarifications are an important part of the bill's overall goal to clarify the regulatory landscape of ASFs in the district, which would be beneficial to both the provider community and DC Health's enforcement activities. In summary, DC Health strongly supports this legislation and appreciates the Committee on Health bringing attention to it. This legislation will clarify and modernize the district's ASF standards, which should improve the overall healthcare system in the district. Thank you for providing me the opportunity to testify, and I'm available to respond to any questions the committee may have.
Thank you both for that testimony. I swear every time we have a hearing, I learn something new in terms of the things that are being brought to the table. So Ms. Cooper, I'll start with you just because we've been talking about ASFs. Whew, that's a tough one, but nonetheless, we were just talking about it. So how many ambulatory surgical facilities currently operate in the district?
There are 5 licensed ambulatory surgical facilities in the district.
Okay. And are they clustered in one particular area of the city, or do we have? I was going to ask a question, but then I already answered it. No, we don't have one in every quadrant. So I guess I'm just sort of trying to understand. So what is the difference between an ambulatory surgical facility and, say, a traditional hospital?
So a traditional hospital, it would be based on the level of care that the individual is receiving post-operatively, what the requirements would be based on that physician's determination of what the needs are. And I think it's important to note that for both entities to start the process, they would first go through this certificate of need process.
Okay, so everybody has to go through SHPTA.
Yes, SHPTA would make the determination of what the entity, the provider is coming and saying, hey, I want to open up a business that does these things. And SHPTA would make the determination and say, how many do we already have in the district? Where are they located? What is the need we're seeing based on data that may be reported through other entities with DC Health? Not necessarily HRLA, but other, fractions of DC Health collect certain data. And so they're looking at that information, looking what the healthcare landscape is of whether or not that need is present for additional ones in the district to determine whether or not it's appropriate for that entity to open where they are proposing, or is it saying, hey, we see the need, but that what you're asking to do is not really needed in that particular area. So maybe consider another place within the district.
Right.
And all of that happens through the conversation with SHPTA before they would come to HRLA for licensing.
Okay. So what are some of the common procedures or surgeries that you would see at a ambulatory surgical facility?
Endoscopy procedures are the most common that we see, along with I think like, I want to say it's not the proper terminology, urinary procedures.
The what procedures?
I was going to say like urological. Thank you. I couldn't think of the word. Thank you. Yes. procedures of that nature are what we most commonly see. And because majority of the ambulatory surgical facilities are doing procedures that are elective,
Right.
right? So they're not medical necessity type of procedures. And that's why, also during the pandemic, majority of these clinics did not really operate, partially because at that time they could not, because
They weren't.
we weren't allowed to do non-necessity procedures. And so at that point, at one time, there was an allowance for them to be used as satellite locations for hospitals by the federal government because of the surge with admissions to hospitals.
Understood. Okay, this is helpful context. So just for my clarification, I guess if a business was only engaged in the practice of plastic surgery, elective, where would that fall?
They would first go to SHPTA. For SHPTA to make a determination based on what the procedures that they're describing that they're doing, and looking at what the recovery period would be, what medications would be needed, what type of anesthetics would be used. All of those things are taken into consideration with SHPTA, along with what the regulations say in the definition, to see what type of facility that would fall under. If SHPTA were to make a determination that it is an ASF, in their CON approval documentation, they then direct them to come to HRLA for licensing.
Okay. All right. So one of the things that stood out to me about when my staff was giving me the background on this legislation was that the bill amends the Ambulatory Surgical Facilities Amendment Act of 1985. And that it seems to me, but you tell me if I'm wrong, that DC Health has been trying to issue regulations on this for at least 40 years now. Like, this bill was before my time. So what's happened? Why is it taking us now to 2023 to like make some of these changes? And I know that's before your time too. There were lots of decisions that were made prior to. I'm trying to understand how we got here.
Right. So I think it's fair to say that it has not been a full 40 years that we have been in
37 and a half, sure. But
right. I think that a lot of things come into play. I think that DC Health was attempting initially to make great efforts to comply with the way that the law was written and develop this list. That proved very difficult.
Okay.
And I think that in trying to draft the list, as I indicated in my testimony, with an ever-changing healthcare system, you may think that you have a list now. 2 weeks later, something changes, you're doing it more.
Okay,
and
so
then
in the absence of that list, does that mean that there's been no oversight? Because I think that's the concern that people would have, is that like we've had this on the books and it's just been sitting and there has been no enforcement or oversight under it.
That would not be correct.
Okay.
We still have regular oversight, and the 5 licensed ambulatory surgical facilities are surveyed for an annual comprehensive healthcare inspection each year. In our oversight questions for our last oversight hearing, we actually displayed that they had all received them. They will all receive one this year. And we also do our regulatory oversight based on complaints, if we may receive any.
Okay.
Or if a facility may contact us and say that something has occurred. And so then we may go out to look at them and make sure that they have complied with local and federal laws if they are a certified facility.
So you were here for the public witness testimony. Dr. Floyd from Planned Parenthood brought to the forefront a potential amendment to just clarify that abortion and other related procedures not be considered surgery. Is that something that you all would have issues with, or you need to look at this a bit further?
I think that is something that we would need to look at a bit further. We weren't aware of that position prior to today.
Okay.
We can say that the agency she represents is currently a licensed ambulatory surgical facility. So we're in good standing with us. So we're not really sure. So that is something that we would like to take back and have some conversations and reach out to them to fully understand what their concerns are.
Okay, great. Let's do that, because I think as I said to her, I don't think it was anyone's intention to add any more stringent regulations than already exist. But this is good for us to talk about it, just so everybody's on the same page of music.
Correct. I think DC Health is really just trying to clarify the landscape right now with the ambulatory surgical facilities so that we can draft regulations, but not thinking that the regulations will be any more stringent than what they're already being required to do. It's just
Okay,
part of the legislative process is what we're trying to be in compliance with.
awesome. Okay, so let's, Ms. Nixon, I haven't forgotten you. Let's talk a little bit about the health boards. So it sounds like from your testimony, we're going to be getting a lot of nominees here soon. Maybe, maybe not. A third, you said, are currently in process with MODA?
There are currently 11 potential board members, professional board members that are in queue somewhere between MODA and council.
Okay. So I just want to, for folks who may not have listened to our hearings over the last few months, as we have been meeting with some of the professional boards and talking about some of their operations, can you talk a little bit about how high vacancy rates affect not just the ability of the board to operate, but from a workload perspective? You might have some people who are like, you know what, y'all not paying me, and there's only 3 of us, I'm out.
I will say that our current board members, we are very thankful for. They're a very dedicated group for a group of volunteers that are not compensated. We don't provide meals. So it is a challenge.
But y'all don't feed them?
We're not able to.
Okay, keep going.
So the staff and the boards have had to come up with innovative ways to ensure that the work still gets done. Most of the boards, all of the boards have delegated authorities. So in the essence that if in between meetings, staff is able to carry out actions, or the executive director for the board. Some have developed subcommittees to be able to triage the work, application subcommittees that the board has given the authority to approve applications that have issues. So again, they're working through it. One of the things when we do meet potential board members, we're very transparent in the amount of work and dedication that comes with being on the board to be prepared to be able to be effective in the board meetings, and also the other obligations. A lot of our board members are on committees within the national regulatory group. So again, we get the work done, but we've had to come up with innovative ways to make sure that we're doing that.
Okay. For those who are watching, who are like, why is she getting so upset about food? Some of these meetings that these boards have are lengthy. So that's why I was just sort of surprised in any of that. In your testimony, Ms. Nixon, you asked that we remove the cap on how many could be non-residents. And I think you make an interesting point around like, this would not be a going to a non-resident as a first resort, but rather as okay, we have shaken all the trees. We have asked all the questions. We have begged all the people we can, and now we need to sort of go outside of that particular pool. How did you all feel about the requirement that the chair of the board still needs to be a district resident?
We are in agreement with that. We do believe that the chair and of course consumer members should be the residents of the District of Columbia.
Okay. The bill requires that all of the board members be licensed and practicing in relevant health occupation in the district for at least 3 years preceding an appointment. And that non-district residents must continue practicing in the district for the whole time that they serve on the board. Do you all have any concerns about that bifurcation?
No, we don't. I think again, just to reiterate, I think some of the things that we want to make sure is that the individuals who are non-residents are practicing physically in the district. Again, we want to make sure that they have an understanding of the healthcare systems in the district.
Oh, so not just have virtual practice or
correct.
Telehealth.
Correct.
Okay.
As we view telehealth as a modality, again, we want to make sure that they have an understanding of the health system and the landscape of the district and the district's culture. And so being able, selecting individuals who are working physically in the District of Columbia would be our recommendation.
Okay. We've heard from board chairs that at least some of the boards consider quorum to mean a majority of the filled board seats. Is that a practice by all of the boards?
Yes, it's in statute that the quorum is established based on the amount of people who are appointed to the board. So not necessarily, so for example, the Board of Medicine is a 15-member board. We currently have 7 members. So you would go by.
So
the
quorum
number
is
of
4 as
Yes.
opposed to, okay.
Yes.
All right. Hang on 1 second. Okay, so I want to follow up on some of the things that some of the public witnesses brought up. So Mr. Gallagher from the Dental Society, and he's been talking about this for several hearings now, of wanting a requirement that everyone who be on the board be practicing actively at the time. What are your thoughts on that?
So currently 73% of our board members are actively practicing within the District of Columbia. So in our current statute, it just says that they have to be licensed in good standing. It doesn't have a requirement of where they're practicing, but 73% of our current membership do practice actively in the district.
Okay. So Ms. Millar brought up the debt clean hands. Made an interesting argument to say that we have some health professionals who can't be licensed in the district right now because they owe monies to the district in whatever forms that they do. Have you all found this to be an issue when you're now I'm going to focus on board members because that is what this bill is about, not about the larger pool of physicians or professionals who are practicing. Have you all found that to be a challenge when you have recruited folks that they are not passing the clean hands requirement and therefore can't move forward?
That is something I would be unaware of. Again, so with board member appointments, that is truly handled by the mayor's office on talents and appointments. So they do the vetting of the individuals and then they are onboarded by Department of Health. Or the boards. So if those instances are determined, it's determined by MODA's office.
Wait, so you guys don't talk to a nominee before they are nominated?
So we talk to them, but it's in the instance of, again, telling them what the work of the board is, the time constraints, how often we meet. And then the only thing that we confirm for MODA is if their license is in good standing in the District of Columbia.
Okay. And in order to have a license in good standing, you have to be clean hands.
Yes.
Okay. Okay. The final thing that someone brought up was around wanting workforce development to be a part of the work and mission of the boards. And again, maybe outside the scope of this particular legislation, something we could probably come back and talk to in terms of the HORA, but I'm curious in terms of your thoughts on that.
I think all of the boards are looking at that as far as their strategic planning and how they want to engage with their stakeholders, the licensees and the applicants. I think most of the boards do a good job currently. A lot of the boards do outreach or participate in our local with our local programs. We go out to kind of inform them of the licensure process. I think some of the thoughts that the boards are having are starting in a younger group to encourage them to consider entering into the workforce. But as far as the current role of the board, they usually do their outreach within to individuals who are already on that path, like in medical school or during a residency or, obtaining their occupational therapy degree, et cetera.
Okay. All right. Well, I think we were gonna, because we know we have the HORA coming, we're probably going to continue talking about some of these particular issues around the board, their mission, the makeup, scopes of practice, et cetera. And so I look forward to that continuous conversation in the fall. Of course, always welcome for DC Health to send us a draft of said large piece of legislation prior to. But I don't have any further questions and none of my other colleagues are here. So we're going to wrap this up so everybody can go enjoy the rest of their Thursday. I want to thank all of the public witnesses. I want to thank all of our government witnesses and your support teams and colleagues behind you. The record for these 3 bills will remain open until 5 p.m. on July 27th. For the public to submit testimony, you may submit written statements to Ashley Strange at astrange@dccouncil.gov, or you may leave a voicemail at 202-430-6046. If you leave a voicemail, please remember to speak slowly and spell your first and last name for the record. As I mentioned earlier, the council will go on recess from July 15th until September 15th. So we may not, it says we will not, but we may not be holding hearings during that time, although we do have the ability to hold hearings on Medicaid redeterminations if necessary, but we won't be moving any legislation during that time. So for folks who are saying what's going to be the follow-up here, the follow-up is September. We have follow-up, our government partners, we have some follow-up, but the next time we talk about these will be in the fall. The committee will continue working with stakeholders, considering whether to move these bills forward during the recess, and we'll schedule any markups after the council comes back together. There's no further business before the committee. This hearing is adjourned, and this time is now 12:18 p.m. Thank you, everyone. What's that? I know. Healthcare finances.